Good evening, everybody. The topic which I am going to talk about today is biomarkers for immunotherapy. Are all of them required? I have no conflicts of interest. And I will do the talk in the following headings. First, what is a biomarker? Why have a biomarker? And then which, when, and how are the biomarkers for immunotherapy in lung cancer? So definition of a biomarker is a characteristic that is objectively measured and evaluated as an indicator of either a normal biological process or a pathogenic process or a response to a therapeutic intervention. A prognostic biomarker is a biomarker that forecasts the likely course of disease irrespective of treatment. On the other hand, a predictive biomarker is one that forecasts the likely response to a specific treatment. And validation is the process in which you have confirmation by robust statistical methods that a candidate biomarker fulfills conditions which are necessary and sufficient for its use in the clinic. Now, if you can see that there are biomarkers which can be purely prognostic, ones which are purely predictive, or ones which are both prognostic and predictive. What is the need to have a biomarker for immunotherapy? Well, biomarker that helps predict a response to or effectiveness of immunotherapy is needed because these are very expensive drugs with no generics till date, and therefore appropriate patient selection is the key to minimize treatment costs, minimize potential immune-related adverse events, and maximize cost effectiveness, and basically avoiding it in those unlikely to benefit and using it in those who are likely to benefit. Now, if you look at the host-tumor interactions, you can see that there are several potential biomarkers for immunotherapy. We are well aware of Pdl1, tumor mutation burden, tumor infiltrating lymphocytes, and tumor gene signatures. Now, if you look at all of these biomarkers, what you can see is that the one which is the simplest to actually find out is Pdl1 expression based on immunohistochemistry, while for all of the others, it is more complex, going up to gene sequencing or big validated assays. And therefore, let's focus on Pdl1 testing. Now, as you can see that whether it is monotherapy or immunotherapy, chemotherapy combinations, it is Pdl1 which has been the hallmark as a biomarker for immunotherapy. And of course, in the Checkmate 227, both Pdl1 and TMB were assessed. And if you look at the results, the current standard of care, which is a high Pdl1 treated with monotherapy, you can see that it performed very well. On the other hand, for the combinations of immunotherapy and chemotherapy, Pdl1 cutoffs really did not make that much of a difference. Now, if you look at this part, by a meta-analysis and individual patient level analysis, you can see that the survival was correlated very well with Pdl1 expression. For PFS, high Pdl1 did much better than low Pdl1. And similarly, if you look at OS, high Pdl1 did significantly better with as compared to low Pdl1 with hazard ratios of almost 0.41 for PFS and 0.62 for OS. However, if you looked at durable clinical benefit versus non-durable clinical benefits, it is clear that Pdl1 expression alone was insufficient. And we know now that there are genes like KEAP1 and STK11, which may portend resistance to immunotherapy. On the other hand, you may have genes like RYR1 and MGAM, which may enhance the efficacy of immunotherapy. Of course, you can go into more detail with this ISLC Atlas of Pdl1 testing and also read this Blueprint Phase 2 project, which tried to harmonize these assays. Now, this part is very important because if you looked at the dominant IHC clone which is used, it is 22C3 in North America, Europe, and Central and South America. On the other hand, for Asia, where we live, and Oceania, it is actually SP263. So regarding Pdl1, the key takeaway points are that Pdl1 expression on tumor tissue by immunochemistry remains the most commonly used predictive biomarker for immunotherapy in non-small cell lung cancer. High Pdl1 advanced in metastatic disease without an oncogenic driver, as shown in Keynote 024 and Empower 110. And even for the adjuvant treatment of completely resected early stage NSCLC in the Empower 010 trial, and maybe even for consolidation treatment of locally advanced unresectable stage 3 NSCLC, the Pacific trial in which PDL1 also tended to predict who did better. Now, the predictive role of PDL1 is more important clinically when immunotherapy is being planned as opposed to chemoimmunotherapy combinations. But PDL1 determination is affected by both tumor characteristics, that is tissue heterogeneity, sampling site, etc., as well as by testing variables like the method used, intra and inter-observer variability. Coming now to TNB, this was the Checkmate 227 trial, and this was a rather complicated trial with 6 arms, and it had 2 co-primary endpoints. One was PFS in population selected on the basis of TMB, and OS in population selected on the basis of PDL1 expression. So the primary endpoint for PFS was met with the dual immunotherapy combination as compared to chemotherapy with a hazard ratio of 0.58. However, if you looked at overall survival, the most interesting observation was when you looked at various PDL1 and TMB combinations. And of particular note was that patients who did not have PDL1 expression but had a high tumor mutation burden of more than 10 as defined in this, they seem to derive the maximal benefit with the best hazard ratio of 0.51. However, a more recent paper shows that high TMB fails to predict immune checkpoint blockade response across various cancer types. And what they found was that it is actually the CD8 antigen which really matters. And so you have categories in which CD8 positively correlated with neoantigens and category 2 in which it did not correlate. And if you looked at this, whether it was squamous or adeno, TMB really did not make a difference in terms of overall survival. And what really mattered was the patients who were in category 1. Now, this was true whether TMB was taken as a binary expression or if it was taken as a continuous expression in which it mattered both for overall survival and objective response rates. Now, there is always this talk of whether you can do the same thing in liquid biopsies. Also, we know its advantages being a non-invasive procedure and allowing a more global assessment of the biomarker. And therefore, both PDL1 and TMB have been attempted in liquid biopsy. Now, this was published in Nature Medicine by Dr. Gandara and colleagues. And here, blood-based TMB was used to predict clinical benefit in patients treated with atezolizumab, a PDL1 inhibitor. And so the blood was taken, plasma isolated and cfDNA extracted, and BTMB determined and then used first in a training set in the Poplar trial data set, and then validated in the larger OAK trial. Now, the correlation between blood TMB and tissue TMB is depicted here, and you had shared variants in 60% of the cases, but you had cases in which it was only in tissue around 25% and a similar figure only in blood. Now, if you looked at PFS, the benefit for atezolizumab as compared to docetaxel, remember this was a second line trial, the BTMB more than 16 was the category shown to have the benefit. However, OS, everyone seemed to benefit irrespective of the BTMB cutoff. On the other hand, if you looked at various cutoffs, you can see that with increasing BTMB values, the magnitude of benefit did seem to improve, with the highest benefit for both PFS and OS being seen in the highest BTMB cutoffs. Similarly, PDL1 expression has been tried on circulating tumor cells. And what you can see is that in patients who had high PDL1 CTCs, they seem to derive better benefit with the proportions of partial responses and stable disease much better than in those without PDL1 high CTCs. And if you looked at both PFS and OS and try to look at different cutoffs, it was clear that if you had high CTCs with PDL1 expression, the benefit was more marked. And that was true whether it was monotherapy or combination treatment with chemotherapy. Now, there has been a hype cycle postulated for predictive biomarkers for immunotherapy in lung cancer. And this has basically gone through a phase of technology trigger, a peak of inflated expectations, then a trough of disillusionment, then a scope of enlightenment, and finally a plateau of productivity. And I think it may not be wrong to say that PDL1 has reached this point, and TMB is actually on the down at this point, and the other genomic signatures and TILs are probably at this point of time. And so to summarize, tissue PDL1 expression, despite all its limitations, is still the most commonly used biomarker to guide immunotherapy in non-small cell lung cancer. Other explored biomarkers include TMB in both tissue and blood, tumor infiltrating lymphocytes, and gene expression signatures. And the search for an elusive, near perfect biomarker for immunotherapy in lung cancer continues. Thank you very much.